Hello, and thank you for joining us, the 6th Annual Global Summit, Kidney Disease Innovation, Vox Populi. The time is now to prevent the cure kidney disease. This summit is hosted by the American Association of Kidney Patients in partnership with our allies from the George Washington University School of Medicine and Health Science. My name is Orlando Torres, and I am an AAKP ambassador from Puerto Rico. As a kidney patient for many years, I have experience with in-center dialysis, home dialysis, and transplantation. My professional background includes international company in the pharmaceutical, banking, and health field. On my days in dialysis center, I found AAKP as a great resource for educate myself as a renal patient, and eventually I started to work locally in benefit of my fellow patients as AAKP advocate. This year, the summit theme Vox Populi was purposely and strategically chosen by AAKP for historical meaning, voice of the people. I am one of the people who has chosen to raise my voice in support to the greater care, choice, and innovation in kidney care. And I am one of the voices demanding the change of status quo of kidney medicine. Over 550 million individuals across the world have kidney disease. This number is increasing at an estimated rate of 5 to 7% annually. Every year, we lose thousands of innocent lives to preventable kidney issues and the lack of timely access to treatment. AAKP believes kidney disease is both a workplace and healthcare issue. The disease takes the devastating toll of human life and livelihoods. Most people understand that kidney disease left untreated and untreated can lead to premature death. But many are not aware that the impacts a person's dignity, ability to provide themselves and their families. Kidney disease and outdated treatment can lead to unemployment, underemployment, disability, and dependency. In 2019, AAKP declared the next 10-year decade of kidney disease. The time is now for kidney patient, consumer, healthcare professional, researcher, industry, and all people of goodwill to unite our voice and demand changes. We are optimistic we can and will save more lives, but to do this, we must demand new screw guideline and diagnostic, new biology, and new devices. Together, we can manage and solve this growing global public health crisis. The time is now to elect and appointed leaders worldwide to listen patient voices. Governments must remove the regulatory and payment barriers they create that delay information and prevent timely care access. If government fails to act, we must raise our voice and demand an end negative government determinants of health. Make no mistake, every nation is impacted by kidney disease and millions of people are in risk. The optimistic news is that every person watching this program today can help those impacted by kidney disease and make an impact with their own nation. Through AAKP Global, AAKP is educating patients, care partners, healthcare professionals, and policy leaders across the world on unmet patient needs. Our annual Global Summit of Kidney Disease Innovation has helped put a human face on what is now the 10th leading cause of death based on data from the World Health Organization. We have connected people across the globe in connection purpose larger than every one person or nation. Together, we have increased hope and optimism. So thank you to join us. Your voice is a voice of people, and you can count on AAKP to keep applying throughout the world to create a change. With that, I am honored to serve as a moderator for our session entitled Alternative to Human Organ Xenotransplantation. Our first speaker is Dr. Adam Griesemer. Dr. Griesemer is an associate professor of surgery at NYU Langone Health and the Hassenfeld Children's Hospital. In his pivotal role, he is the surgical director of a pediatric and living donor liver transplantation, as well as the surgical of the pediatric solid organ transplant program. Dr. Griesemer's extensive expertise and dedication have been instrumental in advancing surgical techniques and improving outcomes for both pediatric and adult patients. His pioneering work in the liver transplantation, particularly involving pediatric and living donors, has not only saved countless lives, but has also set new standards in this field. In addition to his clinical accomplishment, Dr. Griesemer is at the forefront of research in xenotransplantation, exploring innovative alternatives to human organ transplantation. His contribution to this cutting-edge field hold great promise for addressing the clinical shortage of donor organs and offering new hope for patients in need. We are honored to have Dr. Griesemer with us today to share his insights and discuss the transformative potential of xenotransplantation. Please join me in welcoming Dr. Griesemer to the program.
Thank you, Orlando. Thank you, AAKP, and thank you, George Washington University, for allowing me to talk to you about our experience in xenotransplantation. So my talk today will focus on the attempts at NYU to translate xenotransplantation of pig kidneys to humans from the lab, where we were doing these experiments in non-human primates, to human recipients, and our very kind of thoughtful and methodical way of proving that this would be safe and effective in human transplants. So our first step in translating xenotransplantation from the laboratory to the clinic involved the use of the decedent model, where we used kidneys from genetically modified pigs and transplanted them to patients that were declared brain dead but were unable to donate their organs to living recipients. So what these patients did, and their generous families did, was donate their entire body to science and the study of xenotransplantation. So our first efforts were transplanting the kidneys from these genetically modified pigs into the femoral vessels of these decedents, where we could continuously monitor the color and the perfusion of the pig kidneys following transplantation. We could monitor their urine output by collecting the urine from the transplanted ureter. And we could perform serial biopsies so that we could assess the evolving immune response to the xenografts in human recipients. This is a picture of that kind of cartoon representation of what we did. And this is the first successful genetically modified pig kidney transplant to a human recipient. It was performed on September 25th, 2021. And as you can see there, the pig kidney looks well perfused and pink. It was making adequate amounts of urine, and actually the amount of urine that was produced by the pig kidney exceeded that of the native kidneys that were left in situ in these decedents. But those kidneys were not producing much urine at the time, and the majority of the renal function in the decedents was being performed by the pig kidney transplants. This allowed us to prove that the pig kidney transplants would not undergo hyperacute rejection due to preformed antibodies that every human has against pig organs, and that we were able to maintain these kidneys through at least the initial period of the innate immune response. Following these initial transplants of pig kidneys to human decedents, we performed 2 transplants of pig hearts to decedents. This allowed us to prove that these transplants could be safe for heart recipients as well, and we determined that the pig hearts had good initial function in the second decedent. In the first decedent, we actually saw, after a period of 24 hours, a slow deterioration of cardiac function in that recipient, and this was consistent with a syndrome called post-transplant cardiac xenograft dysfunction that had been described in primates. So this allowed us to show that a lot of the data that was generated in the primate model did translate accurately to human recipients. Well, both of those transplants were only monitored for approximately 3 days following the transplant, and they showed that initial innate immune response did not cause hyperacute rejection of pig organs in human recipients. We had yet to determine what the adaptive immune response would be like to a pig organ transplant in the decedent model. Therefore, we performed this experiment where we transplanted a genetically modified pig kidney to a human decedent and monitored the decedent for 61 days, a period of time through which the majority of pig kidney transplants are rejected in the primate model. And this would allow plenty of time for the adaptive immune response to be studied and cause an effect of rejection in the pig kidney transplant. One of the other questions that we had to address in these long-term decedent studies was whether or not a brain-dead human could be maintained with stable hemodynamics for a period of time that was long enough for us to study the adaptive immune response. And what you see here is the average mean arterial blood pressure every day in the decedent throughout the 61-day postoperative period. We did have to use low doses of vasopressors at certain times to maintain an adequate mean arterial pressure, but at other times we actually had to use vasodilators to decrease the blood pressure and keep the mean arterial pressure in the normal range. Nevertheless, this decedent was remarkably stable throughout the 2-month postoperative period despite the development of brain death, and we were able to keep the hemodynamics and the perfusion of the kidney quite consistent throughout the entire postoperative time. This slide shows the results of the renal function of the pig kidney transplant in the human decedent throughout the 61-day period. The dark blue line shows the calculated creatinine clearance, which was measured by either 6 or 24-hour urinary creatinine clearance measurements. The yellow line shows the urea clearance that was calculated in the same creatinine clearance measurements. And the red line shows the eGFR, or the calculated GFR, based on current formulas for human kidneys in the decedent model. Additionally, we measured calculated creatinine clearances using nuclear medicine testing at postoperative day 6 and right prior to the explant on postoperative day 59. As you can see, the urinary creatinine clearance was quite remarkably good throughout the first 4 weeks, but following week 4, we had a fall in the calculated creatinine clearance to about 30% of the initial creatinine clearance achieved by the pig kidney. We performed a renal biopsy at that time and saw signs of early AMR that had developed as a result of the adaptive immune response. We were able then to show for the first time effective treatment of xenograft AMR in a human recipient by performing 5 cycles of plasmapheresis that began at week 5 and continued through week 6. Following the completion of these cycles of plasmapheresis, we saw a return of the GFR, the measured GFR, to about 150. However, a week later, it fell again, and a repeat biopsy showed recurrence of AMR. This was then treated by repeat plasmapheresis and the administration of thymoglobulin. And again, we were able to return the GFR and kidney function back to baseline through the effective treatment of xenograft rejection. And at the explant, the calculated creatinine clearance again exceeded 150, and the kidney was functioning beautifully. The decedent model also allowed us to test certain physiologic functions and compatibilities of the pig kidney with the human environment. These tests were directed by Dr. Vashista Tadapudi, a nephrologist at NYU. We measured the ability of the pig kidney to respond to vasopressin and concentrate urine appropriately as a result of vasopressin stimulation. And this was possible because in brain death, the decedents do not make vasopressin. So vasopressin was given exogenously as a continuous infusion. And you can see here on the graph below that low-dose vasopressin was able to achieve normal urine outputs, normal serum sodium, and normal urine osmolality. On day 27, we stopped the vasopressin administration, and we soon observed a rapid increase in urine output, an increase in serum sodium, and a precipitous drop in urine osmolality. We then reinitiated the administration of vasopressin, and we saw a return to normal of the serum sodium, urine output, and urine osmolality, proving that the pig kidney responds appropriately to human vasopressin. Additional advantages of studying xenotransplantation in decedents includes the ability to perform frequent sampling of blood and tissues. This allows us to follow the evolution of the immune response and allows us to look at the early signs of rejection and predictors of rejection in xenotransplantation. These studies here were led by Dr. Brendan Keating at NYU, and he performs a multi-omic analysis of the decedent and their response to the xenograft, including proteomics, lipidomics, metabolomics, single-cell RNA analysis, analysis of the cytokines, and then correlates these with clinical parameters such as AST, ALT, INR, and CK. As you can see here, these are the two results of our heart transplants that were monitored for a short term. In the first decedent, where we saw a decrease in cardiac function after the first initial 24 hours, we were able to show that this was a metabolic profile more consistent with this syndrome of post-transplantation cardiac xenograft dysfunction rather than due to rejection. This allows us to definitively prove the causes of any xenograft dysfunction that we observe in the future. Transplants in the human decedent model also allow us to do frequent biopsies of the xenografts and to do high-level immunologic analysis of the immune response that is elicited by the xenografts in human recipients. The slide here shows studies performed by Dr. Alex Lupi of the Paris Transplant Group. He was able to survey both the innate and the adaptive immune response to the xenografts at multiple time points post-transplantation. We were also able to assess the infiltration of neutrophils and monocytes into various areas of the kidney, including the glomerulus and the tubules, that allows us to examine the innate immune response and its evolution throughout time. This can lead to the development of further genetic modifications of the pig that will be necessary to prevent both the innate and the adaptive immune response to pig xenografts. Following the successful performance of these transplants in the human decedent model, we then began to perform clinical transplants of pig xenografts to human recipients. This slide shows Dr. Robert Montgomery performing the anastomosis of the second pig kidney that was transplanted to a living human recipient. This recipient had both cardiac and kidney failure and received a left ventricular assist device implantation the week prior to her kidney xenograft transplantation. On the top right, you can see the pig kidney immediately post-reperfusion. It became pink immediately and began working within several seconds of reperfusion. And below the pig kidney perfusion, you can actually see the urine that was produced by the pig kidney soon after the anastomosis was complete. This slide shows some of the clinical parameters of this recipient of the LVAD and pig kidney xenograft transplantation. Following the performance of the LVAD implantation, this patient did not achieve much pulsatile arterial flow. And you can see this represented in the systolic blood pressure and the mean arterial pressure graphs at the top of this slide. In fact, to achieve a systolic blood pressure over 100 consistently, we had to administer low-dose vasopressors to this recipient. And on the bottom slide is the urine output per day in the yellow bars, and the red line represents the serum creatinine in this recipient. Early on, we had a rise in serum creatinine that was corrected simply by increasing the pulsatile perfusion to the pig kidney. This, at day 7, corrected down to a creatinine of 0.5 with excellent urine output. For the first month, we achieved excellent kidney function. However, after this, we experienced several episodes of decreased urine output and hypotension, and the creatinine began to steadily climb. We were able to correct the climb in the creatinine with a fall in the creatinine between weeks 5 and week 6 with a correction of the systolic blood pressure. However, there were several episodes of severe hypotension that again led to a rise in serum creatinine, and due to fluid overload that complicated the management of the LVAD, we reinitiated dialysis in the 6th week following transplant, And given this and her deconditioned state, we felt it was better if we stopped immunosuppression and performed an explant of the xenograft, which was done just short of 7 weeks post-transplantation. Thereafter, the patient was maintained on CVVH following the kidney explant. Analysis of the kidney graft initially reveals that this is likely due to hypoperfusion of the kidney, but we're examining what proportion of renal graft dysfunction was caused by any immune response, although these analyses at this point are at the early stages. So at NYU, we have gone through a very methodical and rational progression from short-term survival of xenografts in the decedent model to long-term survival of xenografts in the decedent model to eventual clinical translation of these strategies of xenotransplantation to living humans. We have learned a lot about the human immune response to xenografts. We've learned a lot about the treatment of rejection of humans to pig kidneys. And we're hoping to be able to continue to improve on the results of living human recipients to xenografts and look forward to bringing this into a standard of care for patients with renal failure. Thank you.
Thank you, Dr. Griesemer, for your excellent presentation. We have a few questions that we'd like to ask you. Are there any concern about future xenotransplant kidney recipients being more susceptible to viruses like COVID-19 or bird flu versus the regular population or those with human kidney transplant?
Thank you for that excellent question. Any patient that is on immunosuppression will be more susceptible to infection from any particular virus and will have a harder time recovering from that viral infection. Currently, recipients of xenotransplants receive higher doses of immunosuppressants and some novel immunosuppressants that we think are more powerful than what is considered standard of care for human kidney transplants. So although I don't think they're higher risk for contracting these infections de novo, once they do become infected with any virus, whether it's COVID-19 or bird flu, they will have a harder time recovering from the symptoms of those infections. But I don't think that they're at any greater risk for contracting them due to than the general population of human kidney transplant recipients.
I have a follow-up question for you. Also, will your xenotransplant recipient be more likely to carry viruses or be host the new COVID or other virus variants because they are immunosuppressed and have a pig kidney?
So again, any patient that is immunosuppressed and contracts one of these viruses will have a harder time clearing the virus from their system. And during that time, it is possible that these viruses can mutate and gain increased virulence or become more susceptible for transmission. But I don't think that they're at any greater risk for that than anybody else who has these viruses and is immunosuppressed because they have an organ transplant or they're receiving chemotherapy or any other reason that patients have compromised immune systems.
Can you talk about how different countries plan to regulate xenotransplantation research or clinical trials?
So xenotransplantation research has been going on for a number of years. I started doing research in non-human primates over 20 years ago in xenografts. So the research in non-human primates is overseen by IACUCs to make sure that it is ethically appropriate, but there are no specific regulations in terms of monitoring the researchers that are performing this transplant for the infection of pig viruses or transmission of pig viruses. Now, in human transplantation, that is different. The FDA has regulations and guidance that requires anyone who comes into contact with a recipient of a xenograft or any recipient of xenografts to submit a blood sample so that we can monitor them for the development of viruses that might have been transmitted to them as a result of them receiving an organ from a different species. These concerns exist because there are several examples of animal infections that have been transmitted to humans. We think that the risk of this is low when we use pigs for several reasons. Pigs are not nearly as related to us as non-human primates are. So primates, we're much more worried about viruses that infect them to be able to infect humans. And we've cohabited with pigs for thousands of years. So any currently existing pig virus that could have infected humans probably would have by now. That doesn't rule out the development of a new virus or a mutation of an existing virus to become more virulent or to be able to infect humans as a result of a xenograft. So monitoring recipients, monitoring care teams, monitoring family members of xenograft recipients, at least in the early stages, is going to be critical. And those are the guidances that are in place for transplants in the United States. Europe is a little bit cooler right now on the idea of xenotransplantation, and they're probably going to lag behind us. The other country that is really leading the way in xenotransplantation right now is China. They have performed several transplants to decedents, and they have performed several transplants to living humans, mostly focused on liver at this moment. And it is unclear what the guidances are going to be for monitoring those recipients, monitoring their care teams, and monitoring their families. But we're hopeful to learn more about that in the near future.
Discuss the potential for xenotransplantation to be integrated into standard medical practice in the next decade. What new system will be needed in item of A, the hospital system, B, transplant center, C, post-transplant follow-up care?
So this is an excellent question because xenotransplantation has the potential to completely transform the field. There are, as most of you know, currently over 100,000 people waiting for a transplant on the waiting list right now. That represents a very small fraction of the people who could benefit from organ transplantation. And if we were able to solve the organ shortage problem through xenotransplantation, it is likely that we could transplant hundreds of thousands of people per year and decrease the burden of dialysis in the United States. However, the infrastructure of the healthcare system is not ready for this at this moment. We would need to rapidly increase the number of transplant nephrologists, transplant surgeons, and we would have to develop a system to transport the organs from special farms where these pigs are raised to the transplant centers where the transplants are being performed. Currently, the pigs that we're using for these transplants are reared in specific pathogen-free environments, and they are very closely monitored for the development of any infections so that we monitor them closely for any viruses that have the potential to transplant, to be transmitted to humans or cause dysfunction of the pig kidneys following transplant. So we will need the transportation structure, we will need the healthcare structure to change rapidly overnight, and then we would also need to develop techniques to monitor the recipients for the development of any signs of infection and prove that if they developed an infection, it is not as a result of them receiving a pig organ, but just general post-transplant infections that all of our patients currently get following the recipient or the receipt of a human organ transplant and immunosuppression.
How might xenotransplantation impact global health disparities and access to transplant service?
Well, one of the big challenges we have as a field of transplantation are supplying organs to everyone that need them. And right now, the biggest disparity and healthcare inequity is the pipeline for listing patients for transplant. Patients with good health insurance typically have a faster path to being listed for transplant and therefore receiving transplant. So as we expand the ability to perform these transplants, it's going to be very critical that we keep a close eye and monitor the pathway to listing people for transplant to make sure that we don't introduce additional disparities and that we are pushing forward and promoting transplantation for people of all socioeconomic backgrounds and all ethnic backgrounds as well. I think we have the ability with the expansion of the donor pool to really address those inequities, but there's also the possibility that we might actually enhance them.
Again, we thank Dr. Griesemer for the insightful presentation into the next future of kidney transplantation.